I completely immersed myself in bariatric surgery nutrition. I'm one of the co-authors of the guidelines. I'm also on the committee of IFSO to write the international guidelines for bariatric nutrition, so we're really excited to start that project. Let me just see if I can get my slides up. Okay, I think. All right, let me just get to the beginning here.
Yes, we can. Yes,
Can
we
you
can
see it?
Yeah, we can see you well.
All right, perfect. Can you hear me okay?
Yeah, everything is perfect.
Okay, wonderful. So thank you so much again for inviting me this morning or this afternoon to speak. It sounds like a very lively activity there. I wish I was there in person, so thank you so much for the invite. This is my email address. Please feel free to email any questions. Let's continue the dialogue. I love our interaction with the international community, so please, please, I'd like to see some emails. So this is my disclosure statement, none of which will affect a bias on my presentation today. And this, at your leisure, you can read my speaker bio. Okay. So what are we actually talking about today? We're actually going to be talking about pre-surgery deficiencies and how important it actually is to do a pre-surgery nutrition assessment on all bariatric surgery candidates. I'm going to list and comprise a pre-surgery evaluation of these deficiencies so you can better address them in your practice. Hopefully at the end of this presentation, we're going to realize the critical importance and goals of a preoperative nutrition evaluation and how this is actually going to affect your postoperative outcomes. And I'm also going to help suggest a realistic dietary intervention to actually help you help your patients resolve some of these comorbidities and micronutrient deficiencies prior to surgery. I think we would be remiss to talk about pre-surgery deficiencies if we didn't actually go to the beginning of the story. And the beginning of the story is that obesity is a malnutrition. Now, it might be misjudged that because our patients are presenting with excessive weight that they're actually increasing their intake. But unfortunately, when we see in the real world, many of our patients are not overdoing calories. Yes, a majority might be, but some of them are not. So we cannot assume that obesity is just because of an intake of excessive calories. Malnutrition, if you remember, is actually defined as any kind of deficiency, either in intake of specific nutrients or utilization of these vital nutrients that are needed for tissue maintenance and repair that would negatively impact the growth or the physical health of that particular patient. And the reason why we're very concerned about patients going into surgery with malnutrition is because the research strongly suggests that patients that enter surgery, whether it's bariatric surgery or any other kind of surgery with malnutrition, are going to have poorer post-operative outcomes. There's going to be increased overall morbidity and possibly mortality and longer hospital stays, increased risk of infection, etc. So the goal of a nutritionist on your team is to certainly address these this malnutrition and micronutrient deficiencies prior to surgery. Now, when you look at some of the official definitions of malnutrition according to the World Health data, it can arise because of hunger and undernourishment, obesity and overnourishment, and of course I put a red arrow there because again, I don't believe that obesity is just because of overnutrition, and micronutrient deficiencies falls within the definition of a malnutrition. Now, characteristics of malnutrition according to the American Society of Parenteral and Enteral Nutrition, your patient would have to present with at least two of these: insufficient energy intake, weight loss, loss of muscle mass, loss of subcutaneous fat, local or generalized fluid accumulation, diminished functional status. Now, the ones that I've highlighted are the ones that our patients with obesity will present with. So there we go. We know that our patients are presenting with malnutrition. Now, when you look at the definition globally, the World Health Organization does estimate that more than 2 billion people worldwide actually suffers from micronutrient deficiencies, at least one, and we're seeing, unfortunately, many, more than one. And this is why micronutrient deficiency is also referred to as the hidden hunger. Now, I thought this was a very interesting comparative. When we compare our two countries, India and the United States, we have some similarities when it comes to micronutrient deficiencies and some dissimilarities. When we look at India, we see a very high risk of B12 deficiency, and that's probably secondary to the vegetarian diets. But we're also seeing a similarity in anemia, iron deficiency, low ferritin levels, especially between both countries. Iron deficiency anemia is still the #1 form of anemia in the United States and the world. We've got zinc deficiency and vitamin C deficiency seen in India, which is not typically seen in the United States, and we don't typically see a B12 deficiency. It's at lower levels in the United States, probably because of our very high intake of animal proteins. Now, I wanted to show you this. I put this together as a summary of some of the literature as recent as 2019 to show that bariatric surgery candidates are presenting with nutrient deficiencies. And again, it's not surprising that we're seeing them deficient in the iron status, the hemoglobin, deficiencies in vitamin B1. Oops. Can you still hear me? Because the internet connection is unstable. We're seeing vitamin D deficiency, we're seeing folic acid deficiency, and I think the most disheartening thing about this slide is that when I was writing the guidelines for ASMBS for the nutrition, we were going back to literature all the way back to the 1990s, and we were still seeing the same exact deficiencies, which leads me to believe that we are not addressing these deficiencies in these bariatric surgery candidates. And you have to, you have to think of why. I know in the United States, many of the insurance companies are having nutritionists do diets with the patients. And I'm almost wondering, are we addressing the micronutrient deficiencies? And I think one of the challenges here in the United States is the insurance companies, if they pay for laboratory biochemistries and they have to get them again prior to surgery, the insurance companies will not cover that. And that would be a very high expense for the patient. So many of our patients are delaying biochemistries. So they're presenting to my office as a nutritionist to help them with nutrition counseling, and unfortunately, I don't have their lab work to address their micronutrient deficiencies. But there's still a suggestion, so I'm going to show you what that is in a minute. So in summary, really, when you look at worldwide, what are these deficiencies seen in these patients presenting for surgery? Well, we're seeing them in the fat-soluble vitamins, vitamin D, A, and E, sometimes vitamin K, water-soluble vitamins, B1 especially, B12, vitamin C, B6, and even folic acid. But also remember the iron, copper, zinc, selenium, calcium, and phosphorus is also presenting, the electrolytes, and also other nutritional parameters that we nutritionists look at. We're going to be looking at the albumin, the pre-albumin, the MCVs, and the transferrin. Now, why do we see such malnutrition and obesity? Well, we've got two sides of the coin. One side might be their diet. Okay, these diets, some of them are very high in sugar and fat. We're eating a lot of processed foods, low intake of fruits and vegetables, and unfortunately excessive alcohol intake as well. But we have to remember that obesity itself is a disease. Obesity is an inflammatory disease. When we look at C-reactive protein of these patients that present, it's very high. And if we remember that high C-reactive protein actually increases vitamin deficiency in and of itself, independent of food intake. Obesity itself is a malabsorptive disease. When we look at the GI tract of many patients that present with obesity, we've got severe morbidity. We've got GERD, we have malabsorption, we have pancreatitis, we have fatty liver disease. In and of itself, that is going to cause a deficiency in micronutrients. And remember, there is a difference between sarcopenic obesity versus metabolic obesity. Sarcopenic obesity presents as a very high percentage of body fat compared to lean body muscle. The higher the body fat, the higher the body water. And in essence, that could cause a volumetric dilution factor, which actually affects the electrolytes. And when you look at metabolic obesity, for example, obesity that also coexists with diabesity or diabetes, we know that diabetes also presents with many comorbid conditions, including micronutrient deficiencies. Even things like choline and selenium and vitamin D will present in type 2 diabetes. So this is definitely a place of opportunity for dietitians to be part of the assessment process before surgery. I think we also have to remember one challenge that we have is patients that go for bariatric surgery, unfortunately, may not come back for follow-up. This is a very big challenge that we're having in the United States. Patients are not coming back for follow-up. When you look at the literature, it's as high as 63%. And we know that patients that don't come back for follow-up after bariatric surgery will be at more risk of postoperative complications. Okay, and we also know that the actual surgery itself, no matter which surgery they're getting, could be a type of malabsorption. You know, I'm a dietitian that actually kind of says that the sleeve gastrectomy, although the majority of cases are sleeve gastrectomy, we have to remember that anything that is affecting the stomach will also affect the absorption of these nutrients. So in essence, it really is a malabsorptive procedure as well. Now, is pre-op deficiency actually a predictor of post-operative deficiency? And that's a very important question, because if our patients are going into surgery deficient and we don't address it, is that condition going to be exacerbated or worsened, or are we going to see other deficiencies arise after surgery? So when you look at the literature here, Ben Parat and colleagues actually showed in the sleeve gastrectomy that if they're presenting with hemoglobin, iron, ferritin, which is the anemia profile, it's actually not getting better after surgery. B12 doesn't get better after surgery. Folic acid doesn't get slightly better, probably because of supplementation. Vitamin D doesn't get better. So patients that are presenting with micronutrient deficiencies going into surgery are going to come out of surgery with them and be exacerbated. This is at 1 year, even though they might be taking supplementation. And we're also seeing that in the gastric bypass. Same parameters. When you're looking at the iron status, B12, vitamin D, folic acid, we're still seeing that exacerbated after surgery. So what are we supposed to be doing? Well, when you look at all the current clinical practice guidelines, even from back to 2008, and these are international guidelines as well, the United States, Israel, India, it is requiring a pre-assessment of these patients. Now, is that happening in every single case? I don't know. I can only speak for the United States. We are requiring that our patients go through a full nutrition screening. This is from the Mechanic 2013 guideline, ASMBS. So what are we doing as part of our practice as of registered dietitians? We're doing a full nutrition assessment, which actually includes gathering data as much as we can, not just food intake. So if there are doctors in the room, if we can order labs, especially certain labs for vitamins, that would be very helpful for the nutritionist to address these things before surgery. I also wanted to mention that we as nutritionists do something called a nutrition-focused physical exam. So we're also looking at the patient. We might actually be touching the patient as well to identify any potential nutrient deficiencies. I'm actually going to come back to this in a minute. So what are the goals of our bariatric nutrition pre-op screening and assessment? Well, the number one goal is to optimize the preoperative nutrition status by identifying and correcting nutrition deficiencies, as well as educating our patient on their responsibility after surgery of vitamin intake and healthy intake. So this is what we recommend in terms of our nutritional pre-op biochemistries. We're recommending a complete metabolic profile. We're recommending prealbumin, lipids, the A1C, especially if they present with diabetes, the entire iron status, so we're looking at iron, ferritin, transferritin, saturation, TIBC. If we're able to order a copper, that would be great because we know that anemia can also be a copper deficiency. We're looking at PT and PTT. We're looking at thyroid panel. Of course, we're looking at a vitamin D, a zinc. Vitamin B1, extremely important. Please put that on your protocol if you don't have it. B12 is important, but even more important is an MMA, which is a methylmalonic acid, especially in patients that have history of peripheral neuropathy and or diabetes. We would love to have a homocysteine, especially in patients that have cardiovascular issues, folate, vitamin A, vitamin E, especially if they're going for more malabsorptive procedures, vitamin K, and then, of course, PTH for malabsorptive procedures. If you can get a baseline bone density, that would be even better. So we have the baseline because we do know that metabolic bone disease is prevalent post-op surgery. Now, again, this list is ideal. If this is something that we can't do, we're going to have to kind of triage and decide which are the most important. Of course, I think they're all important, but a lot of insurance companies here in the United States wouldn't cover a lot of these things, so our patients would have to pay for it, and unfortunately, they wouldn't have the funds to do that. So we might pick the important ones out. So CMP, maybe prealbumin. I have to tell you, I don't really test for prealbumin too much just because the other factors that might decrease prealbumin. B12, MMA, the whole entire iron status, zinc, thiamine, vitamin D. So we have to kind of pick and choose in this country which are the most important. If they're presenting with any kind of nutrition focused physical exam that might indicate a vitamin A deficiency, then I might order a vitamin A. So this slide is just showing you how important nutritionists are in assessing the patients and doing a nutrition-focused physical exam. If they're talking to the patient and they're talking about numbness and tingling, and we don't have lab work, the red flag is going to go up that the patient might have some sort of B deficiency. Now, it might be a vitamin B1, it might be a vitamin B12. It actually might be a vitamin D or a calcium deficiency because they do present with very similar symptoms. The differential would be to get the labs, if we could do that. Leg cramping could be calcium, but it could also be vitamin D. So there's a lot of cross deficiencies here. Certainly, if you have a patient that presents with the more serious vitamin A deficiency, this is going to be a very dangerous situation for our patient to go into surgery with. So I would suggest certainly taking care of that before they go into surgery. Zinc, copper, vitamin K, and vitamin E, you know, again, we're doing a visual assessment even on their hair, their skin, their nails. We're looking at that as well. But remember, there's a lot of cross-reactivity between deficiencies. So if you have nail abnormalities, that could be a copper deficiency, it could be a zinc deficiency, it could be a vitamin A deficiency, it could be an iron deficiency. But these are very important things to note for the doctor as well. So the question is, if our patient is found to be deficient in our screening and assessment, then what do we do about it? How do we actually replete them? Well, certainly as nutritionists, we're doing a patient-centered approach. One diet doesn't work for everybody. But these guidelines are actually published. The American Society for Parenteral and Enteral Nutrition does give us some guidelines on what to do for malnutrition. So we are looking at their energy or their calorie intake to be 25 to 30 kcals per kilogram of body weight, unless they're in critical condition in the ICU. And then we tend to undernourish a little bit. We hold back on the calories. Protein, we're going to increase to 1.2 to 2 grams per kilogram of body weight. Fat, we're going to limit to 2.5 grams. Carbohydrate, we're still giving at 60 to 70% of their calories. And certainly don't forget the fluid at 30 to 40 mLs per kilogram. But I think more importantly, we have to also address the vitamins. I will recommend a daily multivitamin to all my patients prior to surgery to try to capture some of these deficiencies prior. The current research, there is a great study by Schiavo 2019 that just showed that if we were able to address these deficiencies going into surgery, we are not seeing any new deficiencies at 3 months, 6 months, and 12 months. And that study was actually done on the sleeve gastrectomy. So actually, what is the message to take to practice? Bariatric surgery candidates will absolutely present with malnutrition. That's going to increase risk of morbidity and possibly mortality in the patients postoperatively. It will cause an exacerbation of micronutrient deficiencies after surgery, and loss to follow-up is only going to worsen the effect. Careful pre-screening and assessment is necessary and optimal to prior to surgery to make sure that we're taking care of the patient prior to surgery to increase positive patient outcomes after surgery. This is something that we have to do as an interdisciplinary team. We need to work together, doctors, nurses, nutritionists, to try to take care of the patient's nutritional status prior to surgery, and certainly strongly encourage and recommend postoperative follow-up in order to monitor for a lifelong the micronutrients. Those are my references. Hopefully you'll enjoy reading some of those. And thank you very much for the opportunity to present to you this afternoon. Thank you.
Thank you very much. And
thank you.
It was a really useful talk. We were waiting since morning. And I know it's early morning in your place. And thank you very much for waking up so early on a
Of course.
morning.
Thank you for inviting me.
So we'll now move on to the next talk, which would be from Maria. Maria, are you ready?